Morning, folks. I'm watching the clock up here and thinking, oh, I've got loads to go. It's not one of my leadership attributes is being on time, unfortunately. So anyway, this morning we're going to be on time. So thanks everybody for coming this morning. And I don't know how many people got online, but welcome online as well. So this morning I've taken the opportunity and the privilege of taking a bit of your time to talk about leadership development. And Dr. James Helman, one of my esteemed colleagues, who's done a lot of leadership in his life, is going to be helping me with this presentation. So very grateful, Jim, for all of your support. Also very grateful to Doreen and Sanj Gupta, who've also been helping with some of my thoughts and ideas around leadership development and how we support our departments. I wanted to give you a little bit of a talk through with that and talk about the how, well, the why, the how, and the when of how we're going to do this. And first thing, I'll see if I can get our slide to advance. Yes, there we go. Fantastic. So what are the objectives of this this presentation today and the program overall? So understand the importance of leadership in anesthesia and pain medicine, understand the influence we all have as leaders, and describe a leadership development structure to support future leaders in our department. So I put this slide up of our last Weber dinner, 2024, with all of our colleagues on there. Doesn't include our fellows and residents, so I apologize for your absence. You're a very, very important part of our team. But I just wanted to put this up there just to tell you how proud I am to be a member of this department and to be the chief of this department. This is an incredible department, and you all do things every day that both improve and save patients' lives. And I know you know that, but I'm saying that because it's not often recognized by the general public and sometimes by our hospital leaders and by other people in our hospital environment. You just need to come through the ground floor of the hospital every day and see. I mean, as much as I love Francis Wright, our chief of surgery, it says Francis Wright, who leads a great team of surgeons at Sunnybrook. It doesn't talk about the great team of anesthesiologists and other people in the operating room that really save people's lives every day. So I just wanted to start off by saying how proud I am to be the chief of this department and the great work that you do both in anesthesia and perioperative medicine and pain medicine on a daily basis. Has anybody read this story about this lady? Anybody know about this? Yeah. This is a Fanny Burney, who was an English novelist around the early 1800s. Before the advent of anesthesia, she had a mastectomy. And she describes this. If you can go online and look up Fanny Burney mastectomy, you can read her account of the mastectomy. It's absolutely horrific to read that account. And she actually had the mastectomy by Napoleon's surgeon, a guy called Larrey, who was famous for doing the fastest amputation. This was after the Napoleonic Wars. He was across in England doing this surgery for Fanny Burney. And just the account of her mastectomy without anesthesia is absolutely horrific, I would say. And I put this up there both for you to go and read this afterwards, but just to give you what we all know every day is how important what we do for patients. The miracle of anesthesia really is a miracle. And I think it's undervalued and underestimated sometimes in our community. And I just want to reinforce how important that is. And you know, the British Medical Journal, I think it was in 2007, did a survey. They were celebrating starting the origin of the British Medical Journal in 1840, and they had a survey across, I think it was across the UK, maybe across the world, across medical practitioners. What was the most important advance in medicine since 1840? So anesthesia was number 3. Number 1 was public health and things like, you know, you probably heard of John Snow and the pump in London in the 1840s with cholera, and number 2 was antibiotics. So anesthesia, the 3rd most important advance in medicine. I wanted to talk a little bit about why I do this job, and you know, it is a privilege to be in this position I'm in today. I do this primarily because the thing I get up for every day is to influence the way we care for patients. and to try and advance the way we care for patients. And I know that's in the heart of all of what you do as well. And if I can be in a position where I can help to influence the way we care for patients in a more effective way, then that is something that brings me great satisfaction in my career. The second reason I do this job is to maintain respect for our role in clinical care. I'm incredibly proud of our specialty. I strongly believe that anesthesia is the practice of medicine, and we are all physicians first and anesthesiologists second. And what we do every day is the practice of medicine. It's an incredibly complicated field. And I only realized this when I sat the LMCC in Canada in 2000. After I came to Canada from the UK, I'd sat my FRCA in Britain in 1996 and passed it on the third attempt, I should add. I'm not great at passing exams first time, as those that know when I sat the Royal College exam here also know. But anyway, sat the LMCC and was amazed at how much medicine, surgery, a little bit of psychiatry, pediatrics, all the medicine that I knew, primarily from doing my role as an anesthetist. So we are great physicians, and I'm very, very passionate about maintaining the respect that our role has, both in the hospital and the university and in the wider public. And lastly, I very much enjoy engaging in a dynamic and fast-moving system with other motivated and very smart individuals. All of you in this room, I've said on many occasions, and I'll say it again, I'm not the smartest person around the table. You are all likely a lot smarter than I am, and I need your thoughts and your leadership and the way that you think we should move things forwards to help us all move our team forwards. So why should you lead? Well, when I was, if I look at some of our residents around the table today, when I was at your stage, I never could see myself as being a chief of department in 20 years' time. That just was not something I could see myself doing, primarily because I didn't have the confidence to say, yes, I could do that. How did I get started? I get started by having a passion for something. I came to Canada. I was working with Vincent Chan and colleagues at Toronto Western. We were doing some great work in ultrasound and regional. I had a real passion for that. And through that, I sort of built my way forwards into learning how to lead and being interested in leadership positions. But leadership is about influence. And I think I read a quote the other day that said something like, all of us influence 10,000 people in our lives. So we can all influence those people for either the good or in negative ways as well. And if you can influence those people in positive ways, think of the impact that you can have. And I've certainly got many, many people in my career that have impacted me in a positive way. Some of them are sitting around this table today, and they've made me who I am today. So everyone is therefore a leader, whether you like it or not. You're all leaders, especially in the operating room, especially in our clinical environments. And we can all have a positive impact on the people we lead. I'm a strong believer in the old saying, if you're not at the table, you might be on the menu. You need to be at the table when you're having these discussions, and we all need leaders to be at those tables. Sometimes in medicine, that's difficult for us because we're often very busy during the day, but we need to take the time to be at those tables, to influence discussions. Sometimes we're left out of discussions when we're not at the table, not out of any bad intent. It's just because people forget that anesthesia is important. And I've seen that on several occasions since I've started here in the last 3 years even. Don't need to speak to Dave McClain about that, but anyway, cardiac obstetric anesthesia was a great example of that. But we need to be at those tables to influence discussions and influence the way that the university and the hospital moves to take into account the important aspects of anesthesia and pain care for our patients first and foremost. And ultimately that brings advances to our patients and learners through our specialty. So where are we going? Well, we have a very strong university and hospital strategic plan, but we are anesthesiology and pain medicine. Perioperative medicine is also a very, very important part of what we do in our practice. And I think we need to be involved in care and are involved in care right the way from prior to surgery, right the way to days and weeks, sometimes following surgery. Currently in our department, we have specialty leads, and a number of people around the table today who are our specialty leads in the department have done amazing work already in the last number of months since they've been appointed to those positions, leading our quality, our education and research within those specialty areas, and then building excellence across our undergraduate residency and fellowship programs. Our learners, although clinical care is the most important thing that we do, the way that we care and educate and elevate our learners is the second most important thing that we do. And that's a very, very important thing to me in my role. And lastly, research excellence and persistence in research excellence. And you know, we have a number of excellent researchers in our department. We have people who have persisted and then succeeded. I just mentioned very briefly Steve Choi, who's had some good news this week about one of his grants. I think he's put it in for the 6th time and finally had the sort of news that he wanted to hear. So I can't say too much more about that because I don't think it's final news yet, but Steve is just a great example of persistence. I did a little search on ChatGPT. I don't use ChatGPT very much, but I'm starting to learn how to use it a little bit. And this is where it said we're going in the next 10 to 20 years in anesthesia. Why do I highlight this? Because we're going to need to be leaders in our specialty. The people who are in their 20s and 30s and 40s around this table are going to be leading this. So artificial intelligence, personalized medicine and genomics, enhanced monitoring, you know, things like heart rate variability is coming into the fore now. Our expanding role in perioperative medicine, critical care and pain medicine, virtual reality and simulation, and then workforce challenges, how we manage the patients. You know, I think Bev can give us more about our stats, but I think Canada has one of the lowest number of anesthesiologists per 100,000 population in the developed world, which is pretty incredible. I'm going to hand it over to Dr. Helman. Thank you, Jim.
Sure. Well done. Let's see, do I need the mic? Do I need the mic on air?
I'm going to give it
probably switch it over.
just in case.
Just in case. All right. So 2 things out of respect to Dr. McCartney. As you probably noticed on the title slide, I did not have FRCP on there. And the staff was going to put my name in, and I said, I don't deserve those titles. So you guys needed your letters. So I never put FRCP. So I'm not putting that in the past. It did say Colin. So I'm used to seeing slide briefs where it says Colonel. So that's what I thought it was initially when he put it up there. So I thought, well, this is really great. I'm kind of got this all lined up. So I've had the luxury, as most of you know, some of the residents may not know, I'm actually not from Canada. I did have the luxury of serving in the US Army for 22 years and got to lead differently and watch leaders. So actually, majority of these people in this room are already leaders, and you're on different stages of your leadership development journey, I would argue, is how to say this. You probably have seen good leadership. You might have seen examples of bad leadership. And these are some of the styles of leadership that different people operate, and they don't always do the same thing. So I'm not going to survey people to think which one is the best choice. Autocratic, we probably have some examples within Sunnybrook where we see this happen. Not within this room, though, I'm going to say it. Bureaucratic has value, right? There's structure. We know what the rules are going to look like. Transactional. Anybody know what transactional leadership is? You reward or you punish, and it doesn't work out very well. It doesn't last very long. You can do it for a short time. It works well in the Army. So, and what we do with people that are bad leaders that use this style, what we do is we promote them and move them to another unit. That's how we get rid of them. It's like what? Like presidents. Like presidents. It's a very similar model. Democratic works well, equitable, and I think we actually resemble that on times. Laissez-faire, probably not the best style, right? Because then you have no boundaries or guidance. Charismatic. I come from a family of salesmen. My dad is a salesman. My brother's a salesman. We will sell anything to anybody, anytime. Makes it easier if you sell a quality product. But when you talk about products, when we help set up different product lines, when that champion goes away, does the product continue? So what I will speak to, a lot of the leaders in this department have built products that go away when they've handed them off to somebody else. And that speaks volumes to a leadership style. And then transformational. And then the last, which actually is my favorite, let's see if I can do the slides correctly. Which one is it? Is servant leadership. So servant leadership is when you ask this question first with every interaction you do. And I would endorse, this is probably one of the more sustainable leadership styles, but it takes a little bit more effort and work. So when you're building a team, as Dr. McCartney has done and prior leaders have done, when you're building a team, to do this is not easy. And I will say that in my past, I took a leadership course at the age of 54. And I wanted to have people figure out what I did wrong. And what I had learned is the way I lead is and so here's the problem and here's the solution in that corner. I would just go straight to the solution and hope that the team would go with me when I got there. And it turned out that actually doesn't work very well because it'll work for short term, but it doesn't work for long term. Whereas a servant leader will understand, and the line will look like this. The team will progress this way, they'll go down like this. And then the team will go this way and go like this. And an example would be our PACU delay times was a model where it was easy. I kind of knew the answer already. How hard can this be? And it turned out, and you guys had warned me, this is a hard problem. And I'm not the only solution to it. It turned out that the nurses were the solution to the problem. But we had to have them come up with the solutions and embolden them to make change. So the servant leader, which I would endorse as probably the best practice, lead with empathy. Sometimes that takes asking the question and not reflect on yourself, but think about who's in the room with you. Practice self-awareness. One of the challenges, Daniel Kahneman, I won't do justice. Do you know who the Nobel Prize economist wrote a really great book? Unfortunately, he just passed away just recently, matter of fact. Wrote a great book. I would endorse reading it. And what he was dealing with was cognitive bias. How people walk into a room and I see Stephanie sitting there and I'm going to think she's the smartest woman here. And I don't know what's going on here. And I'm going to judge her already just by looking at her. And the problem with that is that I've shut down the conversation and the openness. So the same thing when we see our patients or when you get a group into a room is to eliminate those cognitive biases up front, as Daniel says, because then you don't miss opportunity. So how do you so when you bring a group together, how do you eliminate your bias and be willing to listen? And that's a key part. Probably, now Pablo's not here. I know he won the ultrasound award. For those of you men especially who are raising daughters, I'm going to give you a piece of advice about active listening. There's a great book from the Rotman School of Business about active listening. I want you to think of when you're raising your daughters, I have a daughter, she's now 31, is think of raising a daughter like using ultrasound. So yeah, everybody knows how ultrasound works, right? How much time does the ultrasound transmit? Talk. How often? How long does it go? I don't know. I'll yield to my ultrasound experts. I use it. But how long? Paul, how long does the ultrasound transmit in a given sampling cycle? Yeah, okay. So how much time? Less than 1%. So that's how you should raise. I had to learn how to raise my daughter, was talking 1% and listening 99%. And it actually turned out the relationship changed dramatically when my daughter became 12. That by me listening, and it actually works well for leadership. Supporting others' growth. Making them succeed helps you succeed and be a more sustainable leader. A sense of community. Be transparent. I appreciate the humility of your brief, so thank you for telling your story this morning. It takes a little guts to stand up in front, because typically most of us, and I tell you, especially in the Army, we want to stand up and be like, we are it. We've got the solution. You guys just follow me. It's going to be fine. That doesn't always work. And more often than not, it doesn't work, especially when you go to war. It doesn't work. That worked very well. Inspire with a vision and purpose. There's a book, Peter Block, who's an author out of Cincinnati, who worked with Erhard Berner, who, if you remember from EST, way back in the 90s, a phenomenon here. So Peter Block has said, a leader will actualize hope and possibility in their community. And that would be the definition of an effective leader, to actualize hope and possibility, because there's a huge amount of possibility within this department. And how can we actualize all of that here? Act as a steward. Make sure you check on your team. Make sure you're supporting them as you go forward. Persuade rather than command. Our staff meetings are a great example of how everybody can contribute, bring up ideas, share, and feel safe to do that. How can we do that? And then last, show resilience and adaptability. One of the toughest jobs as a leader, as I look across you all, is navigating your boss and your support staff. And how do you connect those relationships? And lots of times, I know Colin has to do this occasionally, is tell something that he doesn't want to tell because he knows the message isn't going to be well received. So how do we navigate across that here? So it's somewhat difficult. So again, servant leadership. Now, this is a busy slide, and I apologize. Do everybody know who Stephen Covey is? This is an old book. Probably some of the older members in this class. This is a book written in 1989. And Stephen wrote a book called The 7 Habits of Highly Effective People. We could put people and leaders is what could be on this book too. All right. So I apologize, busy slide. So there's a series of habits that Stephen broke down. Be proactive. Focus on what you can control and influence what you can't. Habit 2, have a plan. If you don't have a plan, you can't figure out, it's PDSA. If I don't have a plan, I don't know if I'm getting where I'm supposed to go and how do I adjust. Habit 3, Put things first. Prioritize and achieve your most important goals instead of being reactive to urgency. I hate reactive management. Hate it. Think win-win. All right. So you want to collab. High trust relationships. I think about Stephen Choi and how Stephen engages his community to help others succeed in their research and with the resilience to keep going forward. First one, seek first understand. Again, cognitive bias. Understand your peers. Understand the people that work with you so that then you can understand their viewpoint and why they think the way they think. Don't judge and say you're the only one that's right, but allow to understand them first. I think about Devin. So you have to, when Devin gets a new student that comes in, that's okay. When a new student comes in, they have different needs or wants when they come in. So a challenge every time the site coordinator comes is to understand what are the needs of the students at this point, understand them, because Devin has a prescription of what they want to accomplish, but we also have to understand what they desire to accomplish and meet them in the middle. Synergize, develop innovative solutions, having all the stakeholders. When you have a meeting or project, what you were trying to do, you want to bring all the stakeholders. We did this in the cardiac section. We were trying to figure out changes within cardiac anesthesiology is make sure you bring all the stakeholders in because somebody might mandate to do something, but if you don't have all the stakeholders at the table, you're not going to get buy-in to that product. And then lastly, something called sharpen the saw. So basically stay sharp, take care of yourself, and continue to drive forward. Now, if you break this into two groups, habit 1, 2, and 3, it's important that we take responsibility for our lives and set priorities that we take. This is about self-care, is really what it's about. Know yourself first, continue or try to evolve to know yourself. And then subsequent to that, once you've done that, we build our social awareness and relationship management skills. So you have to reach out and create relationships so that you can have long-term success. I think about Dr. Orser. How many different committees do you have or meetings do you go to on a weekly basis? Can you just give me an estimate? 7? No, I know it's more than that. How many would you say? 10? And then how many people are typically at those meetings?
Ranges.
Yeah.
3 this afternoon.
Yes. So so first of all, you have to get your brain stop, start. And I think about people that go to meetings all day, how difficult that would be. That's one. But 2, how do you make connections amongst that? That's a huge cohort of folks. So how do you maintain those? How do you make the connections and how do you maintain the connections?
So focusing on relationships.
Okay.
Trying to understand the win-wins and synergism and what the problems are, and that takes time. It takes time to an interaction, personal interaction, try and figure out what we're trying to solve together.
Yeah. How do you celebrate those win-wins? Because you did say you recognize them. How do you? Because that's the key part. I know that Colin, I've seen Doreen do it before at different events. How do you celebrate the win-wins? Okay.
I mean, by sharing, by amplifying, by quietly acknowledging, and the list goes on. But I think making everyone feel that they contributed and recognizing the small wins as well as the big ones.
Okay. All right. Thank you. All right. So this is a early form, and what we're looking for is feedback. We're going to have some questions here in a moment. So this is a way that we've used collaboratively. The 4 of us that Colin referenced before have sat down and sort of came up with some ideas, but we want some feedback because this is sort of where we're framed. So first of all, this is going to be a volunteer effort. So you get to choose to want to grow to be a leader. And as I said, a lot of you are very far in your leadership journey. So maybe some of this isn't really value added for you. So we want to be careful with that. So one of the thoughts we had was to facilitate engagement with the leading experts. So have people come in, and Dr. McCartney did this morning, tell their story, how they got there, the why there, the opening of doors, how things changed. So have them be part of perhaps a quarterly grand rounds, to have them. Also to cross over some of the boundaries. You mentioned Dr. Wright. Have them come in and maybe tell their stories so we can break down some of the communication barriers so that they can understand us and perhaps we can understand them and maybe help drive change. Establish mentorship opportunities. I know a lot of you do this already indirectly, so this is actually not new. What we want to do is make sure you maybe formalize it and do some check-ins. We use mentorship system back in Seattle, and what we do is the chief and the vice chief would do check-ins to see how that dynamic was going. Because I know with Jordan, I know Dave and a few other folks connect with you indirectly, and you mentor them all along. It's not that, and what we'd like to do is maybe see what best practices might be. What are best practices for mentorship? Do you ever turn anybody away that asks you to mentor them?
No, of course.
Okay, all right. Because there's all value. We can mentor anybody. As we know, we can educate anybody, so we should be able to mentor anybody. So we're going to probably look for best practices and open up opportunities. So some people might be too shy to not ask. So we want to open that opportunity as we go forward. And then again, we want to check in and sort of learn what best practices might be. Promote continuous education and skill development. Has anybody taken the Myers-Briggs test? For those that haven't, anybody done any personality testing? This is not meant to be, swipe left or swipe right. It's not what this is about. Has anybody done any personality testing at all? I mean, you've done some. Did you find it valuable? Did you? Yeah. So we might actually, so when we do this leadership thing, one of the things that some leadership programs are about is they'll test your strengths and your weaknesses. And what most people have learned is weaknesses are not what you focus on. It's strengths we focus on. And so as Dr. McCartney says, he assembles a team, as Dr. Worcester does, assembles a team of people with different talents, different disparities, who bring different viewpoints. So one thing we would entertain doing is doing some testing. It's okay, it's confidential, it's not meant, but you can disclose it. But what we actually used to do when I started a residency program in the Army, we tested everybody in the department, and we did it intentionally to allow them to know who they were working with and why, because sometimes I'll go, no, I don't do this with Jordan. I'm using Jordan as the example. So why is Jordan doing it that way? Why does he think that way? And sometimes actually some simple testing. It's not absolutely scientific, because there is some softness and it's subjective. So doing some testing to allow to understand what your strengths are, because once we know your strengths, we actually want to capitalize on those and help those develop, is what I would see going forward. There's other programs you can take. I took a one-year leadership program in Seattle, and we can mirror some of that. The Rotman School of Business has a great program. I forget, somebody is participating. Didn't you say you were participating in we're going to talk about that in a sec. I will steal that. And then so there are some educational opportunities. We might have some funding. I'm not giving it away. Just talking about this. We're exploring it, okay? And then lastly, committee participation. The cognitive bias piece that Dr. McCartney is sort of alluding to. If you get on a committee, first of all, it's probably good for promotion, I'm assuming. Committee participation doesn't hurt, right? It also changes your exposure. Actually, I've had some of my best friends come out of committee participation because I meet people outside of anesthesiology. But also you can then indirectly or directly influence the behemoth that is Sunnybrook or the University of Toronto by changing the direction of the path, by bringing Dr. Yee sitting at the table with whomever to share, what do we think? What's our cognitive bias? What's our attitude? So we really encourage this. We found this actually changed. Chief of surgery back in Seattle, he had every member of his team on a major committee in that hospital. And because of that, they actually had big influence. They also drove the economics quite powerfully to do that. Now, Colin made a good point. It's hard to find time. So we need to support time for people to go to meetings too. That is an important piece. That's a bit of how do you strategize the economics of that? Okay. All right. All right, sir. You're up.
Just a couple more slides, and then we'll have time for some discussion and questions for anybody that has any questions. So how developing the next generation of leaders? What sort of skills are we looking for? Well, if we're looking for the most important, or some of the most important skills that we have in our department, are the clinical and operational skills that we see every day. If you see our coordinators that work on a daily basis, they have the clinical and operational skills to keep our department and the hospital running. And ultimately, Jason Tom, our deputy chief, if you look at something like Chris Eidstrup, who's an incredible leader in that regard as well, with the clinical and operational skills, just keep our department going. Those people are vital for our department first and foremost. People like Devin and Elaine, Stephanie, Anita and others with the education skills for training the next generation of anesthesiologists and the great physicians that you are and that you're going to be. And then leadership and research and innovation. But the last two things I just talk about a bit more as well. Sometimes it's having the courage to change. As I showed on that slide, the very basic slide with the ChatGPT, there's going to be a lot of change in the next 10, 20, 30 years in medicine. And we're going to need to be courageous as a specialty to move forwards with those changes and stay at the leading edge of where medicine is going to take us. And sometimes that's going to involve changing our work patterns, in the way that we practice anesthesia, whether we move more towards perioperative medicine and out of the operating room. Who knows where we're going to be going in the future. But there is going to be a lot of change, and that's going to take courage for us all to do that. The one thing that I can tell you for sure is that we are going to be at the forefront of the way that we advance care for patients. We will be. I know that. But that will take courage to step up and do that. And that requires all of you to step up and do that. And lastly, support the team. And I'm doing a course at the moment at the University of Toronto, led by Julie Maggi, called Leading for Wellness. And it's something I've always strongly believed in. I don't know if you can see, it's a very small image here, but it's basically the Maslow hierarchy of needs that many of you will know very well. And we talk a lot at the hospital and the university about the self-actualization piece, how you can be the best that you can be, where you want to go with your career, your leadership, your research, education aspirations, and all of those things. But you can't do any of those things unless you've got the foundation in place with the work-life balance, working in a nurturing and respectful work environment, pride in belonging to an outstanding department, and then having the self-esteem, the mutual respect that we have in our specialty and confidence to do our job. You can't do those things unless you've got all of those things in place. And it's one of my major foci as chief of department to make sure that those things are in place for our team. And that's what I spend a fair bit of my time doing, actually, is fighting some of the battles to protect our work-life balance, protect the way that we do our jobs and the sorts of support structures that we need in place to do our jobs well, ultimately to care for our patients in the best way possible, but ultimately to allow us all to be the best that we can be and to allow us to aspire to those next levels of excellence. So what is your role? Well, we'll talk a little bit more, but attend the leadership development opportunities, consider posted leadership positions in the department, the hospital, and university as they come up. Don't think because you haven't done it before that you can't do it. I very much, maybe I shouldn't say this, but I very much learned on the job. You know, you've got to sometimes just put your hand up and say, I will try that, and seek the mentorship and the coaching and the guidance to be able to do it. So step up for those positions when they come up. As Jim said, let us know how we can improve the program and volunteer to get involved as a mentor or coach. We've got several excellent senior members around the table today. Those people are vital mentors and coaches to our future generation of leaders. And lastly, I'll just, I know people love my quotes, so I'll finish off with this one by Margaret Mead, which I love, which is, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. For anybody that ever doubts that you can't change the world, you definitely can. So I'd like to say thank you, and we'll take any questions or comments, and look forward to moving this program forward. And thank you again, Doreen, Jim, and Sanj, for your support. But
That's how we go.
Okay.
definitely.
Well, thank you very much. That was wonderful. It certainly resonated with me. I think everyone around this room, their leaders, I think my biggest problem, our biggest problem, sometimes we don't see ourselves as leaders and see that it is our opportunity to step up. So thank you for reminding us about that. And another person who thinks the same is Chen, who you mentioned today, who was a leader in ultrasound guided digital anesthesia, and he also saw the need within our department for leadership and established the first chair at the University of Toronto ever in leadership. And just to say that the search is out now for the person who will be the inaugural holder of that chair, and they will be tasked with developing a curriculum and program to help all of us on our leadership journey, just as you're saying, because there are learned skills that we all need, that we continue to learn. And so I'm excited to see who holds that position. And that will start rolling out probably in the spring. Again, curriculum to help us all develop as leaders. But I do want to say how important and how influential this department has been, and many, many people in this department
in terms of changing our department over the last 7 to 10 years. So just thank you to everyone and thank you for focusing our attention on this very important one.
Thank you, Bev. Any other questions or comments? One of the things I would say is, I know you're probably sitting around the table. Some of you will be thinking, I'd like to lead, but I don't know how to. Some of you will be thinking, I can never see myself doing that. I can tell you that some of the people that say, they're sitting there thinking to yourselves, I can never see myself doing that. You will be leaders in the future. Some of you will be. There's no question about that. I was in your position 25 years ago. So the question is how we can help you succeed and thrive in those positions and enjoy them, because they are very, very enjoyable positions. So with that, any other questions before we go? Thoughts? Criticisms? Howard?
Ask an operational question. Thank you very much, guys, for the presentation. Very insightful, very helpful. What's the timeline for something like that, for that mentoring equation you should have to describe there?
Say again, Howard?
What's the timeline for that to come live? Is that a formal program, or is that a kind of an informal program to the mentor and the mentee, and how will that play out?
A great question. I mean, I'll let Jim and Dorian answer that. Yeah. Sorry, Howard was just asking about, is there going to be a timeline for developing the mentor-mentee program that we've talked about? Jim?
So I would argue we should stand up now and create that opportunity. So again, people that want to mentor, I guess, as I referenced Jordan, because he does that, and I know I've seen him do that. His chair is usually full of somebody sitting there, either distracting him from doing his other work or asking him questions. So I know he's busy, so he's gonna be a bit of a pilot to tell us the way to do it. And I don't know if you use any instruments or documents. Do you document any of this?
No, I generally do not.
Okay, and just that for confidence reason or just that's
Confidence.
big extra work?
Yeah.
I'm not trying to create indirect care. So the answer is we should stand this up, and I would like to see it formalized. I don't have to, not the conversation, but to document these are happening. I don't know how this would go for the promotion standpoint, but showing that you are an active participant is a sort of leader role, is what I was describing. A mentor is a leader. So I would like to see us document that. Now, I'm glad to be the recipient as we can archive some of this and then figure out, ask the junior faculty, the senior faculty may be mentors. You know, we all need, I mean, and Bev and I have had chats before. We're still mentoring each other at my very young age, my old age. So those relationships still go on, mentoring is still happening. So in short, I think we should do it now. I would like to see us archive it a little bit, just to say who is what. And you don't have, I used to tell our residents in the past, you don't necessarily have one mentor. Not uncommon, your mentor will change depending on your growth cycle or what your needs are. So it's not one and locked in. We used to assign our residents a mentor, they would stay with them. Those relationships have gone on for years and years and years afterwards here. But you can have more than one mentor too. So I would like to see that. So is that sort of, so
Yes.
it's a loose answer to the question.
I think the mentor thing, like Jim said, you can have different mentors for different areas that you want mentors. So some of it could be as easy as a certain clinical area. Something else could be in education. Something else could be like your finances, someone who's done well. I mean, that's not even to do with the hospital, but like a personal mentor. What did you do with your kids when they went through this? So I think you can have many mentors. But formalize.
Just to chronicle it, I just would like to do that, because then as you go along and somebody says, I would like to find a mentor, we might yes, who might that be? Because they may not, some of the residents may not know who to ask for the fellows. So knowing who's out there and what their perhaps interests are would be useful.
So I think the next steps we're going to do is, we'll have the rounds that Jim talked about, maybe on a quarterly basis, something like that, with some leaders from both within and outside anesthesia to come and speak with us. We're going to develop this mentorship structure in the next couple of weeks, and we'll start moving that out. I think the importance of mentorship is vital. It's when I look to 3 key things that make success. The first one is it's the person with the drive and the passion for doing what you do every day. The second is the mentorship, the guidance, giving you the plan, if you like, or the path forwards. And the third bit is the time. So Jim talked about sharpening the saw. It's very, very important that we all create some time to invest in ourselves and develop ourselves. And that is something I've had the great privilege of having over my career, is having some time to be able to do that. That is an incredible investment in your future. It means when you get to later stages of your career and you're thriving and you're leading, you'll have invested. It's kind of like putting money away for retirement. It's a bit of an investment for yourself every day. So those are the 3 key things I think you need to enable your success, and we're going to try and put those in place for you.
Just in terms of operationalizing this, there are a lot of opportunities here at Sunnybrook for leadership seminars and different things. Is there a point where we can talk about how to make that possible for us to attend? Because unfortunately, those always happen during OR time. We're given short notice for their even occurring. And in general, I can't even say I even think about going to, because I know I won't be able to come up here and say, hey, I'm sure I'd love to go attend the seminar and get out of the hospital. So when we talk about a mechanism, if this is something we're going to do that we can help the staff go through and do some of those things.
Yeah, I think that's very important. I mean, Jim talked about creating the time to attend meetings, and these are some of the important meetings that we need to attend. Yeah. And Jim.
Sorry, no, I just wanted to say maybe there's a way that they can tape those, because that's a chronic problem for everybody.
I don't think taping is always the issue. I think you have to. Some of these things.
No, I agree with you, but I just know the reality of.
Yeah, but I think the reality is I want us to be there.
It would
I don't
be
think
nice.
videos is the way to go about doing something.
Yeah. Jordan.
So general kind of leadership, in addition to the styles that you mentioned, I think there's also locations. The leader does not always have to be in the front. Sometimes you need supporting leaders in the back. And a great way to start is by not being the front leader in the front of a committee, but just being in the background and start off that way. And that's a very useful thing.
Yeah.
And the other thing, I have a quick question for Jim. Would you be willing to send around your top 5 or 10 books on leadership to everyone?
Yeah.
You've read a lot of them, so I think we'd all benefit from that, from a curated list of you. There's so many books out there.
Love it.
It's a passion of mine, so absolutely.
Great, thanks.
Lisa.
I think, Jordan, you also said that one of the most useful things that you learned was a course on,
Conflict management.
that's right.
Yes, if you take one management course, I would say conflict management.
Can you share with me that? Was that a virtual?
That was one of the OMA courses. So the OMA actually has leadership courses,
Okay.
which are very useful, physician leadership courses. And they do one every year, a couple times a year on conflict management. They have other ones as well. But I think conflict management is probably for what we do, people we deal with, is one of the more useful ones.
And Jordan was talking about the importance of the first follower there. I don't know, has anybody ever seen that video on YouTube of the first follower? The guy, the dancing guy? Look it up, dancing guy, first follower. It's a hilarious clip. It just shows the importance of not being the leader, but being the first follower, the first person to get up and be willing to make a fool of yourself with the leader. And that's I'll share it anyway, but it's a funny clip, and it's also quite educational. With that, folks, thank you very much. Thank you for your time.
So people that do have either, Devin, you mentioned what you talked about virtually, or your conflict, the OMA resources. If you wouldn't mind, just sort of feed those into me, and then we'll see if I can put them into some compendium that we can become a whole list for folks to look at. Okay, thank you.
Jordan, you're my